ನಿರಂಜನ್. ಹಾ. ಕೇಳಿಸ್ತಿದೆಯಲ್ಲ ಆಡಿಯೋ ಎಲ್ಲ? ಇದರಲ್ಲಿ ಝೂಮ್ ಅಲ್ಲಿ. ನಿರಂಜನ್. ಹಾ. ಕೇಳಿಸ್ತಿದೆಯಲ್ಲ ಆಡಿಯೋ ಎಲ್ಲ? ಇದರಲ್ಲಿ ಝೂಮ್ ಅಲ್ಲಿ. ಆಡಿಯೋ ಅದು ತಗೊಂತೀನಿ ನಾನು. ಆಡಿಯೋ ಇದು ತಗೊಂಡ್ಲಾ? ಹಾ?
ಹಲೋ 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 ಹಲೋ.
ಆನ್ ಮಾಡೋದ್ರಲ್ಲ. ಚೆಕ್ ಚೆಕ್. ಇನ್ನು ಆಡಿಯೋ ಇಲ್ಲೇ ತಗೋತಾ ಇದೆ. ಬಂದಿದೆಯಲ್ಲ? ಸ್ಪೀಕರ್ ಆಫ್ ಆಗಿದೆ. ಇನ್ನು ಆಡಿಯೋ ಇಲ್ಲೇ ತಗೋತಾ ಇದೆ. ನಂತರ ಅದು ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಇಲ್ಲೇ ಬರ್ತಾ ಇರೋದು ಆಡಿಯೋ. ಲೈವ್ ಸ್ಟ್ರೀಮಿಂಗ್ ಅದು ಬೇರೆ ಬರ್ತಾ ಇದೆ. ಕೊಡ್ಬೇಕಾ? ನಿಂಗೆ ಅಲ್ಲಿ ಕೇಳಿಸಿದೆ ಬೇಕು ನಂಗೆ. ಯೂಸ್ ಮಾಡ್ತೀವಿ.
Hello. Hello.
Hi, Rahul.
Hello. Hello.
Hello. Hello.
Yeah, I can hear you.
It's clear. Voice is clear.
Your voice is clear.
Okay. One minute. I'll share something. Yeah.
Hello.
सर्विस फीस हेयर कट नोज ट्रिम फलाना ढिमकाना कुल मिला के भाई साहब ₹2.5
Welcome to the Cybertruck unveil. We created an exoskeleton. Nice. Now hit the Cybertruck. Yeah. What else can we do with this truck? Let's shoot it. That's a 9mm bullet shot at the door. So it's ultra hard, cold rolled stainless steel alloy that we've developed. We're going to be using the same alloy in the Starship rocket and in the Cybertruck. Let's show the glass demo. So first this is regular glass.
Well-
This is like normal glass, car glass. We want to show
Yes.
you what happens with normal car
Yeah, you
glass.
can hear this thing.
Yeah, I can hear.
No, not me. This audio, whatever is playing.
Yeah, I can hear the audio.
That's
This,
llama
Elon
glass.
Musk.
Yeah.
Yeah, it's full screen now.
Yeah, so still doing it, I guess. Franz, could you try to break this glass, please? Yeah. Sure?
All
Yeah.
clear, right? There.
Yeah, it's clear.
Oh my fucking god.
So what I'm doing now is
Maybe
we
that was
also
a little
have,
too hard.
what do you call the projector.
Yeah.
Okay.
Sorry?
So for projector, we will have to add one more laptop.
Okay.
So we're doing that now.
Okay.
Only for PPTs from here to, because when for Zoom we have connected to camera, we have one laptop. Now here for the audience to view the presentation, I'm putting one more laptop to the projector and adding it.
Okay.
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 Fine.
Hello. Hello. Hello.
Yeah, hello, Satish.
Hi. Good evening, everyone, and welcome to Aroi meeting for the first time for this year. And for this, actually, welcome especially for the one offline where we can meet each other. And like this has been almost like 2 years now. So hopefully this should continue. At least we should catch up for the things what we have not done till now. May continue for at least for every month or so, whoever takes over also. So today's we are looking for a very interesting talk, that is rad. So now actually we have 4 talks in this, and Dr. Radhesham is going to talk about the basics, and afterwards like SBR algorithms and SBRT and by me, and Dr. Munshi is going to talk on immunotherapy and SBRT, and afterwards we have a panel discussion. So first I'll welcome Dr. Radhesham. Dr. Radhesham does not need any introduction to this group, this particular group. Senior medical oncologist from Bangalore, and he is very famous for, especially for his teaching abilities other than these clinicals and out of the box thinking. Dr. Radhesham, sir.
Give it here.
Thank you, Dr. Sridhar. Okay. Yeah. I want to thank Dr. Sridhar, Aroi, as well as Roche for this opportunity. So I'm going to talk about certain basics of immunology, and always the word basics is suspect because that goes on changing. And what was thought to be basics earlier is thought to be now outdated and wrong concept. Anyway, if you, for a long time it was thought that there is an anti-cancer immunity, though people couldn't prove it actually. And if you see here, this is the breast cancer cell, and this is the breast cancer cell, and this is the NK cell, and this is NK cell and a leukemia cell, and we can see here that the leukemia cell is getting destroyed, and similarly the breast cancer cell gets destroyed. So it was known for a long time that these cells are capable of killing cancer, but the question was in the patients it was not happening. And it was also known for some time that if you have a lot of TILs, tumor infiltrating lymphocytes, then your prognosis is better across tumors, across the stages of cancer. So many TILs and less TILs, what we now call as cold tumor, they do uniformly worse than the hot tumors where there are lymphocytic infiltrations. And it was also known for some time that a cold tumor with the introduction of chemotherapy or even radiotherapy can be converted into a hot tumor. So these were known for some time now, even before the immunotherapies were introduced into clinics. What is this? Okay. Now the tumor infiltrating cells may not be uniform. They can be the T helper cells, T cytotoxic cells. They can be even macrophages, neutrophils, and all other things also. And there are some suppressive cells, immunosuppressive cells, called T regulatory cells. So these T regulatory cells suppress the anti-tumor immunity, whereas the T cytotoxic cells and T helper cells improve the immunity. So the ratio of these two was also is being calculated in many of the tumors of what percentage of the TILs are T regulatory cells, and then the prognosis of that tumor is being worked out, or the efficacy, the possible effectiveness of immunotherapy can be assessed to some extent roughly. And the T regulatory cells are known by their CD25 expression. There is a FOXP3 expression, whereas the cytotoxic cells by CD8 expression. So we can now know that this. So if you look at the proportion of T regulatory cells in the TIL, if it's very high proportion, then the patient is going to quickly die. And if the proportion is medium, and then if proportion is low, they are going to do much better. So this cellular immunity, natural cellular immunity, is known to be a very powerful aspect. So people started looking at tumors, classifying tumors into hot tumors where there are a lot of TILs, cold tumors where there is, in the periphery of the tumor there are lymphocytes, but in the core of the tumor, near the cancer cells themselves, there are no lymphocytes. And there is a concept called a desert, where even at the periphery there will be no lymphocytes. Pancreas is a typical example of this, and that's why immunotherapy doesn't work in pancreas at all. GBM can be another example of this. So people looked into a variety of substances which are expressed on the cancer cells. For example, indole imine 2,3-deoxygenase. If it is expressed on the cancer cells, they clear off the area from the lymphocytes. So they don't allow the lymphocytes to go into the tumor at all. Now, one of the aspects was how is it regulated? How the lymphocytes get into the tumor? For a long time, this was a mystery. People thought that just they get into the tumor, but now we know that it is a very active process, and there are several substances which help in this. One of the substances is the prostaglandins. And these prostaglandins play a role in reducing the recruitment of the lymphocytes into the tumor. So many tumors produce prostaglandins, and they reduce the lymphocytic infiltration into the tumor. So one of the defense mechanisms of the cancer cells. And this is another important aspect. This is cancer. This is the bone marrow. And a lot of these immunosuppressive as well as immunomodulatory cells come from the marrow. And one of the very important cells which comes from the marrow, apart from the T regulatory cells, is myeloid-derived stromal cells. These are very immunosuppressive cells, and the tumor produces CXCL1, which in turn act on the marrow and increases MDSC recruitment from the marrow into the tumor, as well as reduce the T cell migration. Double effect, creating an immunosuppressive environment within the tumor. Now, the concept of converting a cold tumor, which I think routinely now pathologists have started giving the reports as cold and hot tumor. It is to some extent useful, though it is not universally standardized. It is known that cold tumors can be converted into hot tumors, and several agents do that. Chemotherapy, radiotherapy can do it very well actually. Biological therapies like bevacizumab can do that, and even targeted treatments including hormone therapy in breast cancer have shown that the cold tumor can become hot tumor. To add to this complexity, it has also been seen that if you give immunotherapy, sometimes immunotherapy itself can convert cold tumor into hot tumors. That's why we should not withhold immunotherapy for cold tumors also, though it has to be generally used along with the other agents. So the immune system normally recognizes and eliminates cancer via multiple complex mechanisms. So this is the tumor microenvironment. There are T cells, there are B cells, there are several other cells, macrophages, for example. For example, there are macrophages which suppress the immunity, and then the T cells get activated, and activated T cells kill the cancer. This is the simplistic view of what happens. And once the tumor dies here, the antigens are presented to the antigen presenting cells, which again is shown to the native T cells, then they get activated. So there are two important mechanisms. One is the APC has to give the antigen, show the antigen to the T cells, and T cells have to recognize it. And the T cells have to get activated and kill the, so there is a recognition function and there is a killing function. Both these can be suppressed by the cancer cells. So we look at when this is so powerful, how the tumor escapes this is the question. So these are the mechanisms of escape. Tumors use very complex overlapping mechanisms, and there are several mechanisms. For example, the tumor antigen presentation itself can become defective because antigen has to be presented along with MHC1, and tumor cells just shed MHC1 so that they cannot be recognized as foreign. The second is there is secretion of immunosuppressive factors by the cancer cells, and one of the most powerful factors is TGF beta. And it has been shown in studies that if your tumor sample of TGF beta is high, or even serum samples are high, those patients are in a very severely immunocompromised condition as far as the tumor is concerned, and your immunotherapy is unlikely to work, at least in isolation. And the third mechanism will be inhibition of attack by the activated cells by disruption of this creation of PDL1 and all that. This is the most important mechanism which is blocked by our pharmaceutically available drugs like Opdata and other drugs available. And the fourth mechanism is the tumor itself recruits immunosuppressive cells. I showed you the T regulatory cells and the stromal cells, myeloid derived stromal cells, MDSC. So these are the four important mechanisms by which the tumor escapes the immune attack. Now we have got different things which can be used. For example, this recruitment of immunosuppressive cell types. This is where the chemotherapy and radiotherapy can work. Chemotherapy kills is very good in killing T regulatory cells. That's why chemotherapy, immunotherapy combination has worked beautifully well. Earlier we used to think that chemotherapy is the opposite of immunotherapy, so they cannot be combined because this suppresses immunity, this stimulates the immunity. But now we know that in a lot of ways, chemotherapy kills these T regulatory cells and myeloid derived stromal cells and converts the immunosuppressive environment to an extent to immunomodulatory environment. And there are no factors, of course, this clinically not very useful still. There are antibodies against TGF beta, and they have tried to block this secretion of immunosuppressive factors. down regulation of MHC, here the NK cell activity, whenever the MHC1 is shed, those cells are killed by the NK cells. So they escape other immune regulation, but NK cells kill it. So when you have this, NK cell therapy can be useful. People have tried that, and to some extent NK cell therapy works. And the most important is this blockade of the activated T cells. They become inactive and they do not attack the cancer cells. So this is where the pharmaceutical immunotherapy comes into play. Sorry, I'm sorry about this, because these were the slides made at that time. So, but the principles remain the same. There is a dendritic cell here, which is the antigen presenting cells. There is a T cell and there is a tumor cell. So there is an interaction between dendritic cell and the T cell, and T cell and the tumor cell. And here the recognition happens. The tumor antigen has to be presented. So this is where the amount of tumor antigen becomes important, and that is where the intensity of chemotherapy and the intensity of radiotherapy makes a difference. If you kill large number of cancer cells and large amount of antigens are released, then the dendritic cells get activated better, and the amount of antigens presented to the T cells is more. So that is where again chemotherapy, radiotherapy interaction with immunotherapy comes in. And there is PD-L1 and PD-1. PD-1 is on the T cell and PD-L1 on the dendritic cell. And when these are expressed, the recognition is blocked. So immunotherapy acts here also. And then once the recognition happens, again there is a block here, PD-L1 and PD-1, where the tumor cells express PD-L1 and again gets blocked here. So PD-L1 expression on the tumor cell is a mechanism by which tumor cells utilize the body's homeostasis to protect itself. Normally also, this PD-L1 expression is important to reduce the immune attack on the self. So autoimmune disorders are prevented because this PD-L1 is expressed on many of the cells. But cancer hijacks this mechanism, this tolerance mechanism, and then protects itself from attack from the T cells. So that is what happens, and all our antibodies block this. Anti-PD-L1 or anti-PD-1 antibodies, we have got about 5 or 6 antibodies available. They block it at this level and at this level. Now, if you look at the research, there are more than, in the research pipeline, there are more than 2,000 immunotherapy agents. This what is available 5, I think it is going to grow by leaps and bounds after some time. There are 164 molecules in clinical research, even more than that now, which block PD-L1 or PD-L1. So that is the magnitude of research going on. 50 of these molecules are in clinical trials, and this is a little old data. Now it must be more than that, more than 1,500 studies going on. And we know that immunotherapy as a single agent is of limited utility. So people are doing most of these studies, 1,100 studies with combinations. We know that it has to be combined with either radiotherapy or chemotherapy or maybe anti-angiogenic therapy and all that. Okay. This is just to tell you a few things. For example, melanoma cells, they thrive and they produce tumors, and they produce TGF-beta, which binds to the lymphocytes, and this is what TGF-beta does to the lymphocytes. It kills the lymphocytes. it kills. So even before the lymphocytes can come to near the melanoma cells, the TGF diffuses into the microenvironment and kills the lymphocytes. This is one mechanism by which the tumor develops resistance to immunotherapy. And this can be by blocking TGF beta, you can reverse this process. Though clinical relevance is not there right now, but I think shortly, I think the results will be better. And this is the mechanism which I wanted to talk to you, that this is MHC, which is expressed on the tumor cells. There is beta 2 microglobulin, which is part of that MHC, and you can see here that this MHC is that beta 2 microglobulin is lost here in this, and when it is lost, the attachment, the antigen, tumor antigen showing to the T cells become defective. So this is another one. IDO catalyzes tryptophan depletion, which regulates immune cells, so reduce T cell proliferation. So it has been seen that if you look at the breast cancer or others, even colorectal cancer or stomach, and if you find that there is an expression of IDO, then there is a reduced efficacy of immunotherapy. So before using immunotherapy, you can do all these things, though they are not routinely clinically available. So, and they have some drugs which are now available, which can block IDO, this indoximod. This is a drug which is being tried out in clinical trials. And there are other intracellular mechanisms by which resistance comes. I don't want to get into all this, but you can see that PI3K, P10 and all that can reduce the immunogenicity of cancer and reduce the activity, T cell activity. So the routine PI3K analysis in the tumor can tell you whether it works, the immunotherapy works or not in the tumor. And there are other things, I think I will, and we also know that if you reduce, if interferon gamma is reduced, increased, then there is increased immune activity, and there is when is loss of interferon, then there is reduced efficacy. In colon cancer, they have seen this, that if you show the loss of interferon, then the immunotherapy doesn't work for that colon cancer. So I think I will. Okay. And this is a very important concept. So earlier we used to use chemotherapy. Then we reached the end of chemotherapy and radiotherapy. And then we started using TKIs. And then the immunotherapy, monotherapy came. And even then, I think majority of the tumors don't respond. And even when they respond, it is for a shorter period. But when you use combination, you really do well. Actually, sometimes the immunotherapy efficacy can increase by 200, 300% when you combine it with chemotherapy, and in addition, you use anti-angiogenic treatment, or when you use chemoradiotherapy and then immunotherapy. So combination becomes very, very important, and usage of immunotherapy as monotherapy, I feel, is waste of money. So these are the number of trials. You can see here that chemotherapy trials 170, then radiotherapy trials are there 64, and the variety of combinations. So you have about more than 1,000 substances which have been combined with immunotherapy as adjuncts. So this is just chemotherapy, how it improves the, it increases the antigen shedding by killing the cancer. It upregulates MHC. It increases the T effector function and all that. So a lot of ways in, and it kills the T regulatory cells and all that and improves the immunity. And this is one trial which showed that combination is better than the. And we can use double immunotherapy. There is a drug called ipilimumab and nivolumab, that combination. So immunotherapy combinations are also going to be effective. And in several tumors, including lung cancer, melanoma, renal cell carcinoma, it can be used. So this is one trial which showed that double immunotherapy is better than either chemotherapy or a single immunotherapy. Bevacizumab, very powerful combination. Bevacizumab is an anti-angiogenic drug, and the border between the chemotherapy, anti-angiogenic therapy, and immunotherapy is getting blurred. We know that chemotherapy itself acts like an immunotherapy. Anti-angiogenic therapy also acts as an immunotherapy. VEGF, which is a factor which is secreted for neoangiogenesis, is a powerful immunosuppressive substance. Now we know that. And if you block that with bevacizumab, not only you improve the circulation within the tumor, hypoxia is relieved, and immune cells can be recruited into the tumor easily, and the immunosuppression is reversed. And with the immunotherapy, it synergizes, and if you add also chemotherapy, you get a great result. So that is what is shown here. Okay, so that is the combination. And in lung cancer, combination of immunotherapy, anti-angiogenic treatment, and chemotherapy has shown good results. Tumor mutation burden is one of the very important factors across tumor types. This is tumor agnostic, tissue agnostic. Whichever tumor which shows tumor mutation, increased tumor mutation burden, you can use immunotherapy. And also there are, if your MSI is high, in several cancers, this TMB can be high. And that means increased expression of neoantigens, and so better response to immunotherapy. So this is the most powerful. MSA high is a very powerful. If MSA is high, the response rates come to around 60-65% with immunotherapy as a monotherapy. When TMB is high, probably it's around 30 to 35% kind of. If you just across types, if you see, it is about 15 to 20%. So unselected is not worth looking at actually, unless you do combination. And there are certain clinical things which you can usually, if you have very chemorefractory cancers, they are more likely to respond to immunotherapy because there will be a lot of mutations in that. And mucin expressing tumors are more likely to respond to immunotherapy. I think I want to stop here. If there are any questions, I think I will be happy to answer. If it's at the end of the talk, I think it's. Thank you.
Thank you, sir, for the wonderful talk. Now I invite Dr. Sridhar PS for the talk on role of SBRT in oligometastasis. Dr. Sridhar PS is the consultant radiation oncologist and head of cyberknife division in HCG Bangalore. Sir.
Thank you, Shyam. So we had a wonderful talk by Dr. Radheshyam. So I tell always the radiation oncologist, the golden era is coming now. So what we thought about like only as a localized treatment, we are getting into a more and more systemic effect. And definitely the coming years are going to be the golden era for radiation oncologists. And we are going to be the main players. So it is not like we are not only limited only to what is so-called increasing the number of patients only limited to the palliative care. So definitely we are looking into a more than that, what we are already doing it. So oligometastasis, role of SBRT. So I'm going to talk about what is oligomets. So there is a thing to be remembered, especially the radiation oncologist. As all of the oncologists, you should know that when to do what time to introduce the radiation. The role of SBRT and oligometastasis. So what is SBRT and how we can include, and some of the cases what our experience is. So if you see the definition, the oligometastatic disease, we call it as OMD. The phenomena, like it is explained almost around 25 years back. The definition goes like this: the intermediate state between local and systemic disease, where radical or local treatment of the primary cancer and all metastatic lesions might have a curative potential. The credit goes to the Elman and Vishardun. And this is where we always talked about staging, early stages, and then the moment if it is oligometastasis, stage 4 versus stage 4, like it is. So now the definition of oligometastatic disease, OMD, has come a long way. So there are initially started as limited disease in terms of single organ or multiple organ or number of lesions. Now it has gone into taken a different. The main things it is to be remembered is it is all clinical based and image based. The whole definition is mainly depends on clinical and imaging. We don't have a biochemical markers, but Dr. Radhesham was suggesting that to identify, to call it as is, can we incorporate that also into the staging like OMD. So oligometastatic disease like mainly refer to the original definitions as I told you. So depending on the outcome, it's actually an intermediate state in which local or treated metastasis control may yield a improved systemic control. So that is one thing we need to look at. Disease burden, limited number of metastasis, oligometastatic defined mainly in the small number of low volume metastasis, 5 or less or 3 or less. Different people have is different. The majority of the time, like it's we take less than 5. So disease burden. So in terms of disease burden, we say like it's a 3 or less, limited number of sites or regions, single or limited numbers of organs, limited numbers of metastasis sites, and limited number of distant metastatic regions, typically less than 5, that contain the primary tumor. So we are looking at about the primary tumor and the number of lesions. Bone is considered as a single organ if we say the multiple lesions, or in take an example of lung and liver, this permutation of combination is going on. Then comes to the disease type. The most of them, like if you say the more indolent disease, tumors featuring limited metastatic capacity. One of the important is the prostate cancers, which has actually changed this overall scenario of how to treat the prostate cancer. Specified for certain organs, limited pulmonary dissemination, limited number of nodal recurrences, especially in prostate and prostate cancers, typically less than 3 or 5. Alternate hypothesis is OMD represents the transition between localized and widespread systemic disease, or the clinical manifestation of a detectable lesions in a setting of widespread occult disease. So synchronous OMD, that is OMD at the time of initial diagnosis, initial diagnosis, primary tumor and limited number of metastases detected simultaneously. So the PET-CT scan is definitely has shown very good, especially to identify that synchronous OMD. The whole staging system has changed because of that upstaging, what we call. So disease load, less than 5 or equal to 5 metastatic lesions with active primary lesions. So we are talking about the primary lesions and other the second the metastatic lesions also. Metachronous OMD often used interchangeably with oligorecurrence. So oligometastatic recurrence during the course of disease at least 3 months after the initial diagnosis. So it still be considered as a metachronous or as a state of metachronous limited recurrence. So the primary may be there, So especially this is seen very often in case of lung and breast cancers. Overall when you see OMD, we are mainly looking at 3 organs, that is prostate, lung and breast. And now we are also looking into the other newer one, including like a cervical cancers or other things with the supraclavicular nodes, distant mets also to be included. Colon is another one. So outcomes: achieve control of metastatic sites and disease load, 1 to several metastatic recurrences in 1 to several organs, and less than 5 metastasis in otherwise well-controlled primary states. So these are the clinical scenarios we see every day. Disease type after primary prostate cancer treatment, less than 3 metastases. Oligoprogression. So oligoprogression, few lesions progress on a background of widespread but stable metastatic disease. So linked with other therapies, that's progression occurs in a limited number of tumors metastases, while the majority of other metastases are responding or stable when a systemic treatment strategy. So progression occurs after a cytoreductive treatment. So this is one, like surgery and radiotherapy acts very important in combination. So progression while other sites, including the primary disease, remain stable on systemic treatment or observational, resistant clones can result in isolated progressions. So that's another one. Disease load less than 5, enlarging metastasis in otherwise well-controlled disease state, less than 5 sites of metastatic disease progression, while other sites, including primary, remain stable on systemic treatment. 3 to 5 slowly progressive metastasis. So oligo persistence. So persistent disease after systemic therapy, that is disease load less than 5 persistent lesions after systemic therapy. So this is definitely a very good articles. Please go through that, and like in terms of definition of oligometastasis, because this is one of the things we can have a whole conference on only oligometastasis, SBRT with the organ specific, and see that. So what we thought that like it is like individually, oh, it is a polymetastatic. Definitely, we are looking into a area where OMD can be treated with effectively with SBRT. So this is some of the examples where we talk about synchronous, the prostate with lesion, which we see almost 40% of our patients are like 40 to 50% are present with metastasis in prostate cancer. Oligo recurrent or metachronous metastasis treated given, afterwards it progresses indifferent, lesion controlled, and if it is another one is oligoprogressive, like castrate resistant and go, some are stable, but you can see still a new lesion. So natural history of oligometastatic disease, mainly in the prostate cancers, most of the times it goes in even in other. So there is a preclinical primary disease localized, and it goes to the next one where there may be oligometastasis to go to polymetastatic disease. First line treatment, then there is a zigzag and going to the terminal event. So this is where like where to put. So oligometastasis is an intermediate state, like where to put it is one of the things, when to interfere, what doses to be used, which are the areas to be treated is to be taken care properly. So what is the theory behind, like we know about that, why there is a clear cut like affinity. We call seed and soil theory for development of mets. So it may mainly the prostate and the other one. There's a particular affinity for the particular tumor, that is seed and soil, that both should be unfavorable to cause that metastatic one. So oligometastatic, the other one plate of prostate, it's with the systemic disease progression. So this is also accepted. So when you know about oligometastatic, it is not only limited. A lot of times when we are an MDT, we call it as one lesion, then only we call it as or one lesion indifferent. No, if you go with the OMD metastatic disease, the lot of what we thought is not the polymetastatic also falling into the oligometastatic disease. In this, actually, then you can segregate into favorable, intermediate, and unfavorable. For probably this will help in the like having a roadmap for a particular patient, what treatment to be used. Favorable, definitely oligo recurrence site, the NSCLCs and renal cell carcinomas where 1 or 2 sites are there. Relatively favorable, we call it as oligo recurrence, especially in the breast cancers and lung, for the bone, lung, and liver and brain for the squamous cell carcinoma, small cell carcinomas, and NSCLCs. Brain and adrenal is a relatively favorable RCCs. So this chunk of the patients we come across a lot. Synchronous oligometastasis, like it is relatively, this also it comes to the relatively favorable. Relatively unfavorable is multiple oligorecurrent site, more than 3 or 5 to a different organs, and synchronous oligometastasis 3 and 5, especially these lesions. Unfavorable, so pancreatic with any site, melanoma, sarcomas, they put it into unfavorable oligometastatic sites. And polymetastasis. So the unfavorable in terms of this is overall, I felt that this is one of the important to have it as a scale to when you are planning your treatment. What is the sweet spot, like it's what when to add if you see the role of oligometastatic disease management. So there is suspected distant mets, we have an MDT always, make sure biopsy. So a lot of times we also see that the metastatic primary biopsy should be done as much as possible. It's not only metastatic sites to be considered, and primary and even the metastatic disease should be biopsied to make sure that all the parameters to be done. So oligometastatic and local ablation, whatever the technique, what is called as metastatic directed therapy should be targeted here. So the clinically relevant, technically feasible, then we have these all the options of treatment, surgery. So one of the things, what is a role of surgery for stage 4 disease in case of prostate cancer and breast cancer is coming up in a big way. I'm happy to see that, like when we say 11,100 this one's the studies are going on in combination of immunotherapy for metastatic disease, where we thought that no, nothing can be done. We are coming to the end of the road there. So then the systemic treatment, local options, there's a lot of things are there, keeping in mind clinical parameters of the patient. So where we stand as an SBRT. So once we finish that oligometastatic as a definition, as a radiation oncologist, we know we are always talked about like adequate treatment to the radiation to the desired dose to the defined targets. So now we are talking about SBRT where we are giving a high dose to the very small target or to the number of targets where you want to one, and the sharp defined targets, very defined doses, and as less as possible to the normal structures with a short dose of durations of treatment. But you need to keep it in mind how to deliver. The motion management has to be very, very good. So with that, high doses, we come to know what is the dose. Per dose is also one of the things we are in debating. Anything between more than 7 gray, it should be good. More than 12 to 14 gray, sometimes they say that immunological effect may go. So these are the effects of hyperfractionations, what we see in that high dose, and especially all these things in terms of ablative direct skill, and Dr. Radhasham has already told the immunological effect and the priming the cells of the radiation for the systemic effect is to be considered. The delivery of the SBRT, like when it is SBRT came almost like I'm doing for the last 12 years. So now actually SBRT is one of the norm. Everybody should be already doing it, number of sites. Does not matter what missions you want to do it, but SBRT should be considered in most of this. So we know about all these things. What is mainly to be what peculiar about SBRT, CyberKnife, which I'm doing for the last 12 years, like it's precision tracking, motion management, high dose delivery, rapid dose fall, patient friendly. So as much as possible, keep it simple, and the patient related factors should be keep it so simple that you should not dependent on the patient. So that is most important. So SBRT for oligomets. So treat mets alone. The controversies are like what we say, how to treat. The treat mets alone is one thing what we did in the past, or treat primary or treat both. So this is always there, like it is, let's say what to do it. SBRT for immunogenic cell death and T cell priming. Yes, when we do high dose of radiations, Dr. Radhesham has already specified the activation of dendritic cells, antigen presenting cells, then it has a T cell priming. This goes and attacks and both locally and in systemic way. So that is the main mechanism what we are talking. And in terms of abscopal effect, the in relation with the immunotherapy attacks in the different cells, and also it goes in as a systemic effect in the one. Can you see the abscopal effect? Clinically, doing more than 1,000 patients, I am yet to see a real abscopal effect, what the people have expressed. Like it's, and most of the times it is a combination of immunotherapy, what we are given. I have my own doubt about one, but probably is when we did it in the past, we always felt that this patient is surviving more than what is given in the literature, where he is not fit to live. So in those cases, the primary is controlled, and even the time progression-free survival is definitely is increased. Like it's, so in those cases, when we see probably the abscopal effect is definitely in there. So advantages of SBRT for oligomets, it's a short duration of treatment. Depending on what is your philosophy, either you want to give 1 fraction, 3 fractions, 5 fractions, 2 fractions, no matter. But yes, so I prefer 5 fractions. I'm more comfortable in giving the SBRT by 5 fractions as a radiobiological basis, and also in terms of patient's comfort and easy to manage. So accurate focused high dose radiation. Yes, it is. We all know about that now. Radiobiological advantages and no delay in systemic therapy. The short course. So the targeted treatment, what we are looking at is finish the SBRT, and probably within 2 weeks we start the systemic treatment. To the extent when we are including immunoradiotherapy, immunorad, we give immunotherapy on the day 1 and start SBRT in the second day and continue. Although there is no and continue immunotherapy thereafter, so that your systemic effect, systemic and local effect is both considered. So immune stimulation of the tumor, synergetic effect with the immunotherapy. Radiobiological advantages, we know there is radiobiologically no repair in intrafractional repair, repopulation, vascular damage, no redistribution, immune stimulation. So also the tumor compartment, other than that, supporting compartment are also getting affected. So Dr. Radhesham was talking about TGF beta. TGF beta, when you see that I attended one of the conferences, TGF beta in different sites have a different action. So you need to be very clear that what is the actions. It has an immunological effect, suppressive effect, and stimulating effect. So it has in different cells, in different types of cells, it has a different effect. So there are now oligometastatic sites in terms of, this is overall when we see the addition of SBRT to the local one, for that it has shown median overall survival of 47 months, 3-year survival of 56 months. This is a pooled analysis. So everywhere, then we talked about BED, the increase in the BED of minimum 75, like the more than 75 BEDs definitely has shown the better results in terms of progression-free survival, overall survival, control of the treated metastasis. So BED to get like 75 plus, so definitely we need to go more than 7 gray per fraction. So 35 to like 7 to 10 gray is definitely an ideal situation. So there is n number of trials. So now, especially if you see the other than the prostate and the lung and the prostate and the breast, all together like you can group almost around 60% of our patients present with metastasis. So these are the patients where we thought that systemic treatment is to be given first. So this actually we can segregate according to the definitions, and in MDT we need to go forward and ask that either to start a trial on our own or to add on the local treatment SBRT as early as possible. So this is on NSCLCs. NSCLCs we have already proven beyond doubt. So that the COMET trial, and we know all the results about that. There's multiple sites, and in addition of SBRT showed the 41 months overall the benefit of almost around more than 2/3. So this is in the same one in terms of progression-free survival. Also, it favors SBBR, stereotactic body radiotherapy, and it comes with a less side effects. So that is the beauty of SBRT. SBRT to the primary is, so it is important. So like especially in the prostate, when we see that the crosstalk between the two things will be stopped. When the primary primary is taken care, even the systemic metastasis which is throws in the different one is also gets reduced. So Stampede trial, which is one of the trials which shows, you name it, they have done trial, everything. So addition of primary. So in most of the times treating both the primary and metastatic versus treating only primary, only metastatic. That's what is they seen, and they seen that there is it favors treating the primary is definitely favorable. So overall it didn't show, but if it is overall survival was not there, but in subset analysis, especially low volume disease, this one treating primary with metastatic disease definitely shows an improvement. So there is the clear cut, especially in the prostate cancer, is going to be our major chunk, like where addition of prostate RT primary, even in a like patients with a metastatic disease, with either the timing of either 3 months, upfront 3 months or 6 months, or up to 1 year, like depending on the oligo progression, recurrence or persisting. So we can consider SBRT in prostate. So this is already there in 2020. So we have we published our data of SBRT with immunotherapy, where we see that there is, compared to the normal without an observation, there is definitely an improvement. So we see mean overall survival is 25 months favoring the SBRT alone and 33 months along with immunotherapy. If you see, most of our patients are actually the brain metastasis. So brain metastasis patients in all the trials are excluded. So this is one of the things where major patients where the intracranial with extracranial lesions, multiple lesions are treated. So going to the biomarkers, can you identify these biomarkers, especially when you are adding? We had a small study also. We are working on that. This is work in progress, talking about interferons, TGF, TNF, and all these parameters to do it. We are almost done around 300 patients now. So we get to analyze that data. The prostate cancer, this is the actually I started in 2009, 2010. So even the Stampede trial started at that time, treating the primary and metastatic disease, especially both chemotherapy and the patients and the hormone treatment. So I always feel when we analyzed patients who had a chemotherapy had a bad prognosis than the addition of SBRT when hormone treatment, where patients who had an hormone treatment. So this is, we see that the 5-year survival was 87.5%, and overall survival is 117%, 117 months. So like it's even in a metastatic disease. So case scenarios. So we had, if I remember correctly, we have done almost more than 1,000 cases of the metastatic disease extracranial. So now this is a, just to give an example, squamous cell carcinoma lung, with you had a chemotherapy where 6 cycles afterward there was a progression in the primary and also liver metastasis. The lesion is almost around 8.5 to 9 centimeter lesion. This is one of my first patients where we added the immunotherapy followed by SBRT. So the first lung lesion was treated exactly after 1 week. We have put the fiducials and waiting. By the time when a rescan, so there is almost around within a span of around 7 days, we saw around 40% reduction in the tumor, and this is where I told that there is a little bit of reduction in the primary liver lesions also. So it may be, this is, we can like consider this is the only place where I've seen what you call the liver mets also decrease. So immunotherapy is also given as a one injection. So there's the biggest challenge is continuing the immunotherapy and the chemotherapy in these patients. Had a 6 cycles, afterwards he stopped. So this is when he came back, the lesions where we treated is almost complete response, and there was a new lesion which we retreated with CyberKnife and then actually put it on a systemic treatment. After almost 1 year, he progressed with ascites. Actually, this is progressed. So like he could not tolerate the chemotherapy and the immunotherapy thereafter and succumbed to the disease. Breast data, around 400 odd patients we have done. Most of them are brain mets and like polymetastatic are in this, if you see oligometastatic disease with the intermediate to unfavorable the diseases. This is one such example. So this is CA breast with a recurrence, was on chemotherapy, but like she was, then there was a mediastinal node and a lung lesion which is treated with CyberKnife, and afterwards continued the systemic treatment. So these are some of the changes after the SBRT you can see, along with only chemotherapy was given. So she was in 2000, after 2.5 years, so she was on maintenance chemotherapy, then progressed in the liver and the brain metastasis. She has exhausted all the chemotherapy. This is where we are added immunotherapy. In this case, this is exactly after 3 months, like for 4 months, when we did the scans. Like this is all CyberKnife done for this case, and there was areas where we treated as reduced, and there is a new lesion in the other one. There's oligo progression, you can see. So those are some of the examples. These are anecdotal cases we are already analyzing. I'm sure that you are also already doing this. And to conclude my talk, definition of oligometastasis, low and high volume, it's already there. We always say that there is no clear definitions. We can definitely go through that and like modify your definitions, and especially in the MDTs, what we do it. SBRT timing, this is definitely to be questioned. I prefer to go as a low volume, treat primary as early as possible, and along with the metastasis, and especially as a polymetastatic, you can always sandwich or consolidate. SBRT to the primary site, if it is possible, please do the SBRT to the primary site in a metastatic disease. Dose radical versus palliative, the moment if you go into the SBRT, I would like to avoid the role of palliative in this one, because you will still be going at minimum of 75 BD, at least a 7 gray per fraction, 6 to 7 gray per fractions is definitely, we are looking at 60 gray equivalent. Re-irradiation, yes, it is possible. In this, there is an oligo progression, especially when there is a reactivation, you can still go and do it. Immunotherapy combination, that is the buzz for now. Dr. Anishil is going to take over and continue with that. Thanks for your patience here.
Comments? If not, we'll go for the next talk. Dr. Anshul Munshi, who is the Senior Consultant and Head Radiation Oncology of Manipal Hospitals, Delhi, will be speaking on the role of radiotherapy and immunotherapy.
Good evening, everyone, and thanks for having invited me to this August event. Over the next 15 or 20 minutes, I'll be sharing some thoughts on immunotherapy and radiotherapy, some basic thoughts and some bit of clinical evidence, because I think we are still in the evolving phase as of now. So coming to the basic rationale of such a combination. So we know that response to immune checkpoint blockade is robust and durable in a proportion of patients. We know that patients with cold or immune deserted, as was being stated, are however less responsive to this kind of blockade, and therefore the need is to develop strategies to inflame tumors, to make them hot. And such strategies are increasingly gaining importance so that there is more response to immunotherapy. The concept of in situ vaccination. So insert immune modulators directly to the tumor environment. Stimulates this action stimulates the patient's immune system, and it can be this agent can be a virus, can be radiation, can be something else. But the common feature is that it's delivered directly into a tumor to help the immune system recognize and attack the malignant cells and possibly other metastatic cells that are here and there. So how can ionizing radiation help here? So ionizing radiation generates death-related signals, including different types of damage associated with molecular patterns, TMPs, reverting the tumor escape from, as was being described, immune surveillance. There's a generalized immune response. And then the checkpoint inhibitors regulate T cell activation and T cell cytolysis of cancer cells, which were suppressed by the tumor before. Also need to remember that while I'm talking about how radiation can help, there is a double-edged sword kind of happening here, because RT can itself induce immunosuppression in a way. So just keep that in mind. So the mechanism of action is that RT given to the primary tumor, tumor-associated antigens presented to the dendritic cells. They present in turn these antigens to the lymph nodes, and lymph nodes then work on the cells, and then activated T cells are released, and then they act on, including all effects, abscopal effects, and so on and so forth. So these are the 4 scenarios. No radiation, then you have increasing, this quadrant shows lower dose radiation, and then you have increasing higher dose, and then very high dose of radiation here. And with each of these, as you go from no radiation to increasingly higher dose of radiation, you have different kinds of effects, starting from vascular normalization, T cell infiltration, novel peptides, upregulation of MHC1, CD8 T cells, to here when you have high doses of radiation, and then you have dying cell necrosis, tumor killing, and so on and so forth, release of cytokines and tumor associated antigen specific phenomena happening there. So with each of these, it's not simple and straightforward. With each level of dose, the effects on the tumor are different. And then there can be effect with fractionation as well. So you have conventional fractionation, for example, the Pacific trial. Use conventional fractionation. You can have hypofractionation, you can have more extreme form of hypofractionation with the SPRT, and then you can have very low dose RT. So, and as I said, for example, with hypofractionation, high dose radiotherapy, you can have mediation of important immunomodulatory effects, in situ vaccination through release of tumor-associated antigen and activation of dendritic cells, normalization of tumor vasculature, and so on and so forth. Taking the case of non-small cell lung cancer, moderate fractionation in the size of 2.5 to 4 gray per fraction. One, it allows acceleration of treatment. A bit of hypofractionation can finish the treatment faster. It can reduce the amount of blood flow. Now, this is an important concept, and increasingly as radiation oncologists, we come across the role of lymphopenia and induced by radiation and how it can affect the outcome of radiation. So here again, it's very important, this concept, because hypofractionation, moderate amount or more amount, can reduce the amount of blood passing through the beam. When the beam is on, the blood is passing through that region, and there is lymphocyte depletion consequently happening. So there is consequently, because of this reduced amount of blood passing, there is reduced duration and severity of radiation induced T cell suppression, T cell and lymphopenia. And there is some bit of evidence also to this effect. A small study, 115 patients. So overall treatment time less than 4 weeks. It significantly decreased the risk of severe lymphopenia. Now, again, if you go very low dose, so you have low dose irradiation with one fraction of say 0.5 to 2 gray, or a few fractions of 0.5 to 2 gray, RT can be considered as a response modifier of immunological agents, and it has shown to be potentially increasing the immunogenicity of cold tumors through several mechanisms. Preferential induction of T regulatory apoptosis, skewed macrophages from M2 phenotype towards an inducible NO synthetase positive M1 phenotype, and so on and so forth. Quite a bit of molecular work has been done in this regard. Now, interestingly, people have gone to the extent of using combination of high dose and low dose, both. So high dose per fraction irradiation of the primary and low dose irradiation of the abscopal tumor, plus anti-PD-1 therapy. All three of them, they achieve the best abscopal responses compared to just two of them together or one of them alone, and so on and so forth. And some bit of clinical data to support this as well. Now, which association should be considered for which objective? Now, I presented you three scenarios. This is limited disease, this is locally advanced disease, this is polymetastatic disease. And these are the typical scenarios we come across in our clinic. So for limited disease, early stage or oligometastatic, backbone is SRT. SRT is the backbone. Added agent is immunotherapy. Objective of the association is in situ vaccination, and importance of local control is extreme. Scenario number 2, locally advanced disease. Backbone is definitive chemoradiation. Added agent is immuno-oncology, immunomodulatory agents. Objective of the association is counteraction of immune suppression plus minus a radiosensitizer effect. Again, importance of local control is still there. In polymetastatic disease, the immune therapy becomes the main driver there. Added agent is radiation, high dose perfection or very low dose. Objective is in situ vaccination and or modification of the immunotherapy response. Importance of local control is not so great, but it is there. So these are the broad concepts that have come up during the past few years. Now, how do we optimize the radiation and immunotherapy combination? How to get the best out of it? So, as I was saying, in limited disease, 3 to 5 fraction, 8 to 10 gray. Locally advanced disease, moderate hypofractionation. Polymetastatic disease, maybe 3 fraction of 8 to 10 gray, or low dose irradiation, 1 to 3 fraction of 0.5 to 2 gray. Target volumes, again, important concept of target volumes. Try to decrease the irradiated tissue volume. That should be the aim. Can be done by several ways. Then again, reduced or no CTV at all can be considered risky, because you are not now targeting the microscopic cells that you were targeting earlier for CTV margins. So can you now, to gain this effect, risk not giving CTV margins? That's the question. Reduce PTV. Partial radiation, concepts of just irradiating half of the tumor and leaving the rest of the half. No elective nodal radiation. All these strategies have been going on in trials. RT techniques, again, SRT if possible, IMRT, triple F, just to increase make the treatment faster. So again, this decreases the irradiated tissue volume, decreases the treatment time, and so on and so forth. And then there is a concept of immune organ at risk. We know OARs. As radiation oncologists, we know what is an OAR. But here we are talking of immune OARs. And then there are certain organs like where we need to kind of, for example, bowel, it said that try to spare it, because that is kind of coming up as an immune OAR. Continuing with the organ-specific effects, SRT to parenchymal sites, for example, liver or lung, can induce changes in systemic immunophenotypes, and various effects can happen because of this. But similar effect is not seen for bone or brain. So this is kind of an organ, and this can be because of difference in antigenic load, relative abundance of innate immune cells and lymphocytes between organs, and so on and so forth. So again, as radiation oncologists, we are going to face target volume controversies. Reduction in tumor target volume is of course desirable, and peritumoral microenvironment rich in immune cells and can contain tertiary lymphoid structures. So there is theoretical sparing of tumor-associated lymphocytes from peritumoral TME. But again, everything is kind of coming at a price. And of course, we know the strategies that have been using, for example, IGRT, 4D techniques, they are essentially reducing the target volume that we are irradiating, in a way helping us towards achieving this mission as well. And peritumoral tumor-infiltrating lymphocytes will mediate the local immune response as they are recruited after irradiation. Those TRLs present within or around the tumor at the time of irradiation, which are thought to be highly radiation sensitive, are killed and cannot play an anti-tumor effective roles. So quite a few concepts going on here. So this is the hypothetical model linking radiation to lymphopenia and to inferior oncological outcomes. So high out of field radiation dose linked to lymphopenia, large radiation volume linked to lymphopenia, long fraction time linked to lymphopenia, high radiation dose to the OARs I was talking about linked to lymphopenia. And sparing lymphatics in radioimmunotherapy is becoming increasingly, it was talked about in ISTRO 2021 also, and when they were said that particularly relevant for head and neck patients, where giving extensive radiation to the lymphatics can actually be problematic. And these are concepts which are really kind of in a way radical. So strategies to reduce RT-induced lymphopenia have been irradiating with SABR, proton beam therapy, hypofractionation, radiosurgery, and so on and so forth. Now coming to the evidence part of it, we know about the PACIFIC trial, the exciting results we saw with the PACIFIC trial, addition of durvalumab after chemoradiotherapy in stage 3 non-small cell lung cancer. There was the 24-month overall survival, 66% in the durvalumab group compared to 55.6% in the placebo group. Again, conventional radiation was here used based on the LQ model, and immunotherapy followed radiotherapy. But there are issues. For example, conventional fractionation, conventional margins are associated with lymphopenia, immune suppression, and that is the problem we are dealing with now. This is a list of prospective studies in stage 3 non-small cell lung cancer. We know the PACIFIC trial, LUN trial again. So there are 2 or 3 kinds of strategies that are happening. We know in PACIFIC and LUN, the sequence was after chemoradiation, durvalumab was added. But now people are saying that, okay, give concurrent and then follow it up with consolidation. Why not give concurrent only and then follow it up with, why only consolidation? So these are the new things that are, and especially in the Nicholas trial and the Detter trial, these concepts are being tried. In metastatic non-small cell lung cancer patients, we have already talked about Sridhar was mentioning about the Pembro-RT trial, where we know the overall response rates, they were almost double in the combination arm. And then 3 or 4 other trials are also phase 2 trials going on in this regard. We are aware about the InPower 133 update. Now, although it was not directed for the radiation part of it, but I would like to mention this trial. It showed exciting data to us in extensive stage small cell lung cancer. However, it has, as radiation oncologists, posed problems also to us, because the focus on this trial was not so much on also incorporating prophylactic cranial radiation or thoracic radiotherapy. So now when such patients come to my clinic, it is definitely some thought I have to give as to what should be the best way forward for such patients who have received immunotherapy. So I feel we should be more pragmatic in designing trials, taking everyone's interests and the data and the clinical data into consideration, because this trial I feel has in a way ignored PCI and thoracic radiotherapy. So this is the current FDA approved situation in terms of immunotherapy for lung. Some updates from the abstract in recent conferences: the Rapaport phase 1, phase 2 trial, median follow-up of around 2.3 years. This was in oligometastatic RCCs, 30 patients, 83 metastasis, multi-site SVBR plus 6 months immunotherapy given was safe. 13% grade 3 toxicity, no grade 4, grade 5 toxicity, 2-year progression-free survival, 45%, local control 92%. In another update on this study, 77% were treated with single fraction SBRT around 20 gray, and for patients who had RCC or melanoma, they said a single fraction perhaps is more stimulatory. And evidence is coming up for other sites: cervical cancer, oligometastatic disease, lung oligometastasis, brain oligometastasis. Regarding the toxicity part, now this again, it's a presentation in itself, but summary is that most of the studies do not find any dramatic increase in toxicity in combination of radiation and immunotherapy agents, like what was earlier believed, because once upon a time, whichever trial was being designed was keeping radiation and immunotherapy miles away, 5 months away, 6 months away, 8 months away. So from there we have cut down the gap, and then we are trying concurrent things now. Neoadjuvant also, concurrent also, adjuvant also. So several hundred trials going on, and let's see what the outcomes are. Flash radiotherapy is also being used now as in trials, because it delivers treatment at an ultra high dose rate, and that can again reduce the lymphopenia part of it. So it has shown consistent normal tissue sparing effects, and compared to conventional RT, flash radiotherapy has shown differential immune responses. So can it be an ideal partner with immunotherapy? Let's see, there are ongoing phase 1, phase 2 trials. So the other question for radiation oncologists is that, are we expecting a synergy between immunotherapy and radiation, by which can we now think of reducing RT doses? Because now we have a very nice partner of immunotherapy piggybacking on which can we now say that, okay, now we'll reduce the RT doses themselves and reduce the side effects? That would be an interesting question. So this is one of my favorite slides, where this is called the hype curve. And the hype curve is relevant for technologies. It is relevant for molecular agents. It is relevant for any exciting thing that comes in the market. So the first is the innovation trigger, this yellow thing. This is the innovation trigger. Lots of excitement is happening. And this is very well relevant for the topic that is being discussed as well. Lots of excitement. Then you reach peak of inflated expectations, at which you feel this is it. This is the thing that is panacea for everything in oncology. So you will try it for anything and everything. And then comes a trough of disillusionment. When trials fail, funding stops, everything stops. At that time, you reach here, some deaths happen, side effects in patients happening. So you reach here then. And after that, there is some slope of enlightenment. There is some hope again that comes. And then you reach a productivity plateau, where you realize, yes, we can do this. This cannot be done. We have to use it here. So I'm sure immunotherapy and radiation is also going to follow this curve. The other question for us as radiation oncologists is radiation really activating the immune system, or is radiation an effective therapeutic partner with immunotherapy? So these are unanswered questions. Is tumoricidal irradiation absolutely required for localized disease when we are combining these agents? Can we pay for de-escalation? Will we be able to define, or should we already start defining new OAR constraints now? How can we better exploit the synergy between RT and immunotherapy? Can we decrease radiation-induced toxicity? Now, this is a kind of a summary slide to which whatever I have spoken so far. So if you want to forget whatever I have spoken so far, that's fine. But just remember this slide. Which RT technique is more immunogenic? SABR rather than conventional RT, every other day rather than consecutive, 6 to 12 gray per fraction rather than higher doses, 24 gray 3 fraction, 30 gray in 5 fraction are the most frequent that have been used in trials. What is the ideal treatment sequence? Concurrent RT with anti-PD-1L1, sequential RT after CTLA-4, anti-CTLA-4. Which lesion should be treated? Multi-site radiation rather than a single site, visceral lesions rather than bone, RT to the lymph nodes and bowel could be detrimental. Partial irradiation of bulky tumors, as I was saying, can also unleash these effects. Are there any biomarkers that can guide us? As was being discussed, high TGF-beta has been associated with worse outcomes. High interferon-1 could influence RT effectiveness. Lymphopenia is a big culprit, can negatively impact the immunogenicity of RT. And currently we don't have any, we must admit there is no currently approved biomarker for clinical use. So this is the final slide. Combination of RT and immunotherapy presents an exciting therapeutic modality. Preliminary data is very exciting, but issues such as dose fractionation, combination, sequencing remain kind of unsolved. So we need to wait for mature data and more outcomes and toxicity outcomes and survival outcomes before we can really make a statement. Thank you so much.
Thank you, sir, for the very nice talk, and it was quite thought provocative. Now we will have a panel discussion. The moderator will be Dr. Jayant Bhargav. He is consultant radiation oncologist at Narayana Rudayalaya Cancer Center, Bangalore. I call upon the panelists also. I call upon Dr. Radhesham Nayak, Dr. Sridhar PS, Dr. Anshul Munshi, Dr. Vinay Ural, consultant radiation oncologist, Apollo Hospital, Bangalore, and pathologist Dr. Kunal Sharma, who is head histopath and Center of Excellence, SRL Labs. I also call Dr. Thiranjan Basu to join us for the panel discussion.
Okay. Watch that, yeah.
Yeah. So after the excellent talks, we'll try and go through a couple of cases. We'll try and tie in everything that's been spoken about over the last 1.5 hours or so. So I'll try and keep it simple. First patient is a 63-year-old gentleman. He's an ex-officer of the Indian Air Force. He was an ever smoker. He quit 2 years ago, no comorbidities. He was evaluated in August 2019 for complaints of cough, 2 months, dyspnea on exertion, and vague pain in the right chest wall, 1 month duration. He visited his family physician who advised the chest X-ray. So that showed an opacity in the right upper zone, and then he was referred to the oncology center for further evaluation. So performance status is good, KPS of 80. Further evaluation, sir, Adesham sir, I could start with you.
Imaging, I think,
Yeah.
PET scan.
So we did a whole body PET scan which showed lesion in the right upper lobe, approximately 5, maybe infiltrating the chest wall. There was also a bulky mediastinal node. So we staged this as, there was no evidence of distant metastasis. So this was in 2019. So after this, we sent him to the interventional radiologist for a CT guided biopsy. Dr. Kunal, we did the biopsy, and this was.
Okay, so this looks like a non-small cell lung cancer and more of an adenocarcinoma. You can see the glands which are being formed there. So
Yeah.
Yeah.
I'm guessing that's the magnified view.
yeah, so basically you see intracellular mucin and you see glands with lumen in between them.
Okay.
So the IHC markers that we do are TTF1 and napsin usually.
I think this was.
Yeah, no, that you can't say. So what we basically say is what subtype is it? So this would be an Assener subtype, because based on the different subtypes, there is prognostication that happens. Plus, sometimes when this can be very difficult to interpret on morphology, because when you have solid nests, they could be non-keratinizing squamous, or there could be adenocarcinomas as well, the solid type, which has a worse prognosis. So in that case, IHCs by TTF1 and napsin
TTF1.
usually help. And you always suggest 2 IHC markers minimum, because there can be overlaps. You can have focal P63 or P40 expression in the case of lung adeno, and you can have focal TTF1 expression in case of a squamous cell carcinoma as well.
Perfect. I was just about to come to that. So P63, P40, and TTF1, one of them.
Another very important thing from pathological evaluation perspective is that whenever I get cores, let's say I've got 4 cores, I prefer to divide them upfront, wherein 2 are used for histopathology and IHC evaluation, and the rest 2 can go for mutation analysis, so that there is no depletion of the tissue and there is no time that is taken. Right?
Perfect.
In pathology, we say tissue is the issue, usually.
So he was diagnosed to have adenocarcinoma right lung, CT3 and 2, and sir, Vinay sir.
Yeah.
Oh, I'm sorry. Yeah.
It's okay. It's a concurrent CTRT is standard nowadays.
Yeah.
And along with that, we can add durvalumab also.
Yeah.
But first thing is, you told he was an army man, and he was not a policeman. So that's very important, because general conditions are very bad in at least Karnataka police. So PFT and other things we have to do, because in radiation, it's very important to see the PFT values and FE1 and what is the cardiac status. And then I'm not sure how many patients will be able to give 66K and 33/11 concurrent chemotherapy. It's very difficult for us unless the patient is very fit, non-smoker.
Okay.
Just wanted to add a couple of points. So in the diagnosis, like the moment if you done the PET CT scans, usually in all lung cancers, I always get it like MRI brain screening is one of the things we always add in all lung cancers.
Yeah.
Early stage, that is one thing I want to add. So any role of genomics here in that at the early stage itself?
So he completed treatment in 2019. I'm just thinking, based on current evidence, would there be a change in practice now? I think sir has spoken about it. Going back to Dr. Kunal, would we do a PDL1? Would we do a TPS for patients who are locally advanced? Is that mandatory?
So I don't take that call.
No.
You have to tell me if you want a PDL1, I'll do it for you. One first thing is that in cases of lung, we generally evaluate TPS scores and not the CPS. The main reason for that is that in lung tumors, the inflammatory cells are very less. So TPS is almost equivalent to CPS. So, and we all know the cutoffs, TPS, I mean, PDL1 low, PDL1 high, more than 50% is high, 1 to 49% is low. But actually, I think the more and more I read further and, we see in clinical practice, PDL1 is actually not an indicator of immunotherapy anymore. It's an indicator of chemotherapy, to be honest, as probably as you introspect on that,
So Radhesham sir, we won't, based on the Pacific trial, they didn't really mandate TPS or PDL1. So everyone ended up receiving.
They don't, but if we get enough tissue, we just do, maybe it is useful, because even in an early tumor where neoadjuvant chemotherapy is given before surgery and all that, people have seen that even the targeted treatments are now coming up before surgery or even after surgery as an adjuvant treatment. So when you are doing one of those targets, you can as well do the PDL1 and do it off.
Okay.
And later it may not be possible to do, because once a patient progresses, you may not have tissue, or he may not be willing to get a biopsy done when it becomes metastatic. And I think, as it was pointed out, there are certain percentage of people who will not tolerate this chemoradiotherapy, and that is substantial percentage actually. And some of them we may need to either dose reduce, which again impairs the survival, or maybe use some of these targeted agents, maybe even weekly chemotherapy. So those kinds of things we do, or reduced doses, even targeted treatment, even immunotherapy, of course, as a neoadjuvant treatment here.
Just a disclaimer, this is just a made up patient. So we didn't really see this patient in the OPD. I just made it up. But
I feel that we should do in all the investigations what we do for metastatic disease.
Okay.
It is better to do. Though it is not standard, I agree. But I think probably it will become standard in some time.
And just another question, sir. In the Indian scenario, if patients are paying for their immunotherapy, even in consolidation, as durvalumab, would it be better to do a EGFR, check if there's a actionable mutation there, and then offer PDL1 to those? Yeah, because it's a lot of money involved. So I'm just thinking, okay.
But I think you need to get a full lung panel done, but that gives a totally different treatment scenarios. Yeah. So I feel that any patients with lung cancer, you should get it done everything.
Yeah. Because sometimes the data says that you don't need to do, but all the data says that whenever PDL1 expression is high, there is much more advantage. When you are asking a patient to spend that kind of money, it is better that you demonstrate some PDL1 expression or more TMB or whatever which is necessary for that immunotherapy is what I think it is.
Okay.
Because your percentage of success may be 15%, 20% in an unselected patient.
Yes.
So
the same patient came back in Jan 2021, approximately, I think 15 months post his completion. Lucky that way. He presented to the ER with complaints of severe headache, 1 episode of seizures, and pain in the lower back. Sir, would you be able to? Evaluation for that.
Since in ER, the first would be to do an MR brain and a spine screen MR. Once he's stabilized, then also maybe a PET CT to see the systemic disease as well.
So I haven't gone into the details, but basically we did the MRI brain with contrast, and there were 3 lesions. One, all tiny ones, one in the right middle frontal gyrus, left parietal cortex, and left cerebellar hemisphere. We also did the PET. There was no evidence of locoregional disease, but there was 1 lesion in L5 involving the body and the right pedicle. There was no evidence of cord impingement. Examination wise, he was okay. Coming back to Dr. Kunal now. So at this point in time, with respect to pathology. So would we use the same old FFP block and do molecular testing, and what all would we ask for at that point in time? Let's assume that we haven't asked for anything initially. So at this point in time, what would we look at?
So as as we always say that you should definitely get the whole lung mutation panel done. Also, it's imperative to understand that PDL1 is through IHC, whereas the other lung parameters would be through NGS. So you should wait for the complete report to come before you start any treatment. Plus, in cases like these, of course, we cannot expect a biopsy from the brain. It's very difficult. So more often than not, we usually, as Radhesham sir said, a lot of people actually have started, prescribing all these tests right up front, because that patient compliance eventually will become a problem.
Sir, would there be a need for a rebiopsy at this point in time? Let's assume we've got sufficient tissue left, but would there still be any need of a rebiopsy?
Ideally, yes, I think because PDL1 is a very dynamic marker if you are looking at PDL1, and even TMB can change over time.
Yeah, exactly.
So if you're looking at immunotherapy, definitely yes. But if you're looking at the molecular, the targeted treatment, probably I think that
it may
change is not that much, I think.
Okay, sir.
Probably we can manage with the old block.
Okay. Is there a role of liquid biopsy in this sort of a setting? Let's assume we don't have sufficient tissue left from the original biopsy.
So definitely for molecular testing, liquid biopsy in lung is, one of the mainstays. And, many a times, like, even if there is a resistance eventually to the first generation TKIs, there are ways to detect T790M mutations and, to start with the other generations of TKIs. So yes, there is a role. And I think we have some beautiful liquid biopsy tests which give us the ability to test all the markers, EGFR, ALK, ROS1, all of them. So definitely, if there is a difficulty in biopsy, maybe, you can go for this.
I was just reading that there's some evidence of exosomal PDL1 on the liquid biopsy. Is that considered equivalent to a tissue? No.
No, not yet.
Okay.
I mean, we of course prefer tissue PDL1s as of now.
Okay, that's good. Is there a role of CPS at all in lung cancer? Small cell? No. Not be. Okay. And are there any new markers like the tumor mutation burden or the microenvironment gene signature?
So yeah, there are tests like these which are available in certain companies. Most of the diagnostic companies don't do them in-house. We do tend to outsource them to other companies. But these are still on a very we don't see them usually for most of the patients.
Okay.
So
he was diagnosed to have metastatic adenocarcinoma, right lung oligometastatic disease. He's got 4 lesions, 3 in the brain, 1 in the bone. PDL1, the TPS was about 25%. KPS is 70. Anushil, sir, would you? Yeah. So I think, maybe we'll just start off with the systemic therapy and then I'll come back to you, sir.
Systemic therapy, I think, depends on several aspects. The most important is what targets we get. And
so let's assume that all the EGFR, yes, EGFR, ALK, ROS, MET, everything is ROS1, everything is negative. It's just PDL1.
And another thing which we have to look at here is the drugs crossing the blood-brain barrier. And right now, I think the immunological agents don't cross that well into the, though the targeted agents, all of them cross. EGFR, anti-EGFR drugs, I think they cross, and anti-ALK drugs also cross to an extent. Another question here probably is whether we can use bevacizumab, because that crosses the blood-brain barrier, it reduces the edema. Probably it can have some effect on the even cancer also. And along with immunotherapy, it may have some role in control of, in addition to whatever radiotherapy can be given. But there is some concern that radiotherapy and bevacizumab interaction. I think majority of the times, I think people avoid that. So that is one. So, secondly, I think the condition of the patient. performance status and all that also is important. Here it appears to be good.
He's okay.
So I think we can even second line treatment if none of the targets are there, and majority of the patients cannot afford the immunotherapy. So chemotherapy also is going to be an option for large number of patients in our setting.
Okay. So is there a role of SBRT in this patient? Let's assume that he's opted for chemotherapy along with immunotherapy. I mean, I'm just.
See, the pressing need is for the brain lesions that this patient has. So you said there are 3 brain lesions.
3 brain lesions.
But you also said they are very small. They are like 1 to 1.5 centimeters. So I assume that none of them is causing some big mass effect or compression that requires decompressive surgery. So these 3 lesions, I think, could be addressed by stereotactic radiosurgery. The vertebral lesion, if it is not causing immediate problems, could be tackled now or at a later date after systemic therapy. I mean, that decision can be taken based on how much compression or whatever impending there is on the vertebral side. So I think that decision can be taken.
So I was just trying to pull out data where they've used chemoimmunotherapy and SBRT. There's hardly any. It's all single arm retrospective, fairly low quality evidence. But brain metastasis, there are a couple of these where they've said that chemotherapy, immunotherapy, and SBRT to the brain lesions kind of improves the in-brain control. It doesn't necessarily do anything about the OS or the PFS or anything, but at least in-brain control is kind of improved. But for extracranial metastasis, I think just going back to Sir's talk where lesions in the bone, lesions in the nodes, they didn't really, I mean, we're still awaiting data. So there's a lot of trials are going on. This review paper is from Jan of 2022. So I've kind of gone back and I've checked if there are any updates. None of them have any. So I think they're still awaiting data. So let's just assume that he ended up getting SBRT as well. So sequencing of immunotherapy and SBRT, sir, Sridhar sir.
I prefer, if in this case, definitely SBRT to all the areas. If you're definitely the lung cancer, if you see 20 years back, we said that is not even 8 to 12 months. Now we are looking for a curative intent in lung cancers because there are so many molecules available and so many targets, and including the SBRT to some of these lesions. So SBRT to the brain, definitely, if it is, considering oligometastatic setup, include when you are doing for that, for the bone is also, I don't think so. Vertebra is something which is bad. In terms of sequencing, the sequencing is not defined.
Not yet.
Not yet. But by preference, I prefer day 1 immunotherapy and then continue SBRT to both the areas 5 days and continue immunotherapy afterwards.
So do we treat one lesion or do we treat all? We're still awaiting data, but in the meanwhile, based on preclinical evidence, more number of lesions we treat, the more dams are released.
All the areas are amenable for SBRT right now. Why you want to leave it like this? Yeah. So if you want to do immunotherapy and like there is only immunotherapy now, the lesions may go away and probably you can wait and watch. That is also a possibility. But this is where like now, if you don't want to treat anything, no immunotherapy, probably I'll do SBRT alone and wait for 3 months and see the biology. So that if it is no immunotherapy at all, systemic treatment can still be avoided if it is possible. If you want to do only SBRT.
So maintenance therapy.
The problem with immunotherapy, of course, because of the cost and all that, and it doesn't work in everybody. That's another issue. So if you give a gap between immunotherapy and radiation, if it is possible, the situation warrants that. I think it is better to see whether immunotherapy is working in somebody, because to continue it as long as the disease is under control is, say, quite 2 years or 3 years of treatment is millions of, I think, several lakh of dollars. So I think we should be careful about that. So that is one thing, dilemma which always we have in the clinical setting, because immunotherapy works in 25% of the people or 30% of the people, not more than that actually. So should we should we see whether it is working or not. And another problem we have is immunotherapy and chemotherapy we combine. And when there is an effect, we don't know what is working. Probably it is chemotherapy working and immunotherapy is not working. And that is a costlier part of it. So we have to look at that also. So these are the issues which come up in the patient because money is limited with the patient. So we need to see what is the most important part of that therapy. Though theoretically, yes, we have to combine everything together, chemo, the immunotherapy, plus maybe SBRT. That's true. The total effect on the tumor will be good, but we don't know really what really is the best combination.
Yes, sir.
So let me put it in the other way. If there is no bony metastasis, only brain mets are there. Probably I'll do only SBRT to the brain and wait and watch, not adding this systemic treatment for time being. So same with like adding this for the bony lesions, SBRT, and only SBRT, wait and watch for 3 months to know the like how is the progression, and then add the systemic.
I added the bony mite just for that. Okay. If there was a actionable driver mutation noted, we would have obviously started with that particular TKI. But in case that patient ends up developing resistance to that TKI, so I think you've already touched upon this point. So there is a role of chemotherapy, immunotherapy, and bevacizumab. If KPS is less than 50, so would you consider immunotherapy at all? Would you consider SBRT at all? That sort of a scenario.
Immunotherapy we can consider, but may not be chemoimmunotherapy. Immunotherapy as a mono treatment, or maybe immunotherapy with bevacizumab or something like that can be tried. And one more point is, if there is resistance to TKI, once they have the mutation, they don't respond well to immunotherapy.
Yes, sir. So point 1 is separate.
Yeah, I know that.
Yeah.
But I was looking at that resistance to TKI
Correct.
and then immunotherapy. Na? So once the TKI is used, and there is a target there, immunotherapy doesn't work well.
Doesn't work well.
We have seen that in our experience, and even literature says that.
Yes, that's true. So if there was disseminated metastasis, choice of systemic therapy again would be dependent on performance status, chemo alone, chemo plus immunotherapy. Yes. So is there a role of SBRT, SRS in case of oligoprogressive disease in this case? Sridhar sir, I think you touched upon this.
Yeah. Definitely. See, especially in the lung, prostate, and breast, I think the SBRT role is coming up in a big way. So as I told you that oligoprogressive and some of these lesions definitely can be done. Even in the KPS 50, if it is there, because of the eloquent area, what is involved is most important versus like why the KPS is low. So that is one thing I would like.
There's a trial called the ARREST trial. They are treating up to 50 lesions with trial only. Up to 50 they are addressing with SBRT. Over 2 to 3 sessions, they will address all 50 of them, up to 50 of them.
Systemic radiation.
It's the ARREST trial. It's being done by recognized investigators in Europe. Let's see what happens.
I like it.
So if this was stage 1 and we offer SBRT or SABR, is there a role of immunotherapy after that? We don't really know, either before that or, so we don't really know. I think we're still waiting. Yeah, I think a lot of trials are happening right now in stage 1. 2 has some data.
So Radhesham sir, like in these cases, immunotherapy like stage 1 or this, how long to continue, when to stop?
Yeah, that's one of the questions we really don't know. And whether it is effective also we don't know. Because after certain stage, maybe the immune suppression starts, and then that's how we don't know about that. It is like anti-angiogenic treatment. When it came to earlier stages and adjuvant treatment, it failed. So only in grossly metastatic disease.
Durvalumab, I don't know how many people have used. Definitely, it is not a very like comfortable in terms of post radiation pneumonitis is concerned. That is, anybody, any experience?
We've got a couple of patients in our hospital, but no. So we quickly go into the second case. I'll keep it short. So 55-year-old gentleman is a professor from a degree college, current smoker, evaluated in September 2020 for cough, hoarseness of voice, and weight loss. CT thorax done elsewhere showed a lesion in the right upper lobe with prominent mediastinal nodes. He was referred. KPS 70, further evaluation. I'll quickly go to, I think we're running short of time, but whole body PET CT, this is what it showed. So it showed a lesion in the right upper lobe, bulky mediastinal nodes, contralateral mediastinal as well. So we did the biopsy. I pulled it off the internet, but yeah. So this is what it looks like.
So see, this is a classic case of a very poorly differentiated tumor. You can't really say on biopsy what this looks like. So this is where we would be needing more of immunohistochemistry. So I wouldn't want to commit on biopsy what this is.
Perfect. So we did IHC, we ordered IHC for that. And then, so pan-CK, TTF1, CK7, synaptophysin positive. Clusters were positive for chromogranin. Ki67 was 90%.
So the moment you have two IHC markers of neuroendocrine positive with a Ki of 90, you're dealing with a small cell carcinoma. You know.
So we did a brain MRI with contrast. There was no evidence of any disease there. Impression, small cell lung cancer, extensive stage. So treatment. Yeah, so we did 3 cycles of neoadjuvant chemo with carboplatin in the top side. So would you have done anything different?
Same, maybe thoracic RT is variable because extensive maybe 13-10 is okay. Some people do 45-15, but since it are extensive, maybe 13-10 is good enough.
So in light of current evidence, I think sir touched upon this Empower 133 data. So we would have probably added on atezolizumab in this case. But I think going back to that trial, I think there was no mention of thoracic RT. I think PCI was permitted in a few subsets, but not very small number. There's no, I think thoracic RT, no one ended up getting it. Also, I think going back to some of the other trials, I think it was the CREST or something. So basically, some of them did 45 gray BD, some of them did 60 gray 30 fractions.
Anshul sir would also agree. If it is limited, then thoracic RT people try for 45. Extensive, there's not much of a difference. There's a small RTOG study. There is no difference between either of the schedule.
Yes. So 6 months later, we ended up getting a whole body PET CT, which revealed 3 metastatic lesions: liver, bone, and adrenal. So any role of immunotherapy at this stage?
Second line, I'm not sure. Maybe irinotecan is one chemotherapy drug which we can use here in this situation. Immunotherapy, we can try it out, though there is no standard indication there.
Any role of SBRT in this case? Sir? Sir? So I think there was just a recent, I think this was in 2020. So immunotherapy with SBRT, relapsed small cell lung cancer. There were also a few patients with metastatic disease. Yeah, there was no benefit. And so now kind of stressing the point that it's better to move towards early stage, not so much in extensive stage. So it's always better to concentrate in the limited stage setting. So there's no evidence at present. So I think I was just going through a lot of papers and then this line popped up somewhere. So in the marriage of SBRT and immunotherapy, we're still in the honeymoon period. Time will tell if these early promises will last.
Jayant, I'm not sure. I mean, honeymoon period. I think it's a dating period. It's a dating period.
They're still in the dating period.
Multiple partners don't need to go for a longer time.
Yeah, I think that's even better, sir. Yeah. Thank you all for your patience. Yeah.
we will be starting the GBM of Aroi, Karnataka. I request all the non-members of Aroi, Karnataka to please leave the hall. You can, we have started the bar and the dinner outside. You can start off. We will finish it quickly and we will join you. Okay. I call Dr. Rupesh, Treasurer, Dr. Mohan, Joint Secretary, Saurabh, Executive Committee, to kindly come forward. I request Dr. Sridhar, President, Aroi, to start off the proceedings.
ಎಲ್ಲಿಂದನೇ ಮಾಡೋದು ಈ ಫಸ್ಟ್ ಅವ್ರು ಅದಕ್ಕಿಂತ ಮುಂಚೆ ಆಗಿತ್ತು ಮತ್ತೆ ಮಾಡ್ಬಿಡೋಣ ಆಗಿತ್ತು So welcome for the first GBM of 2021 and post-COVID, yeah, first GBM post-COVID. So only executive committee people are there. I don't know, like it's, sir, please sit down, sir. So where is Sham? Sham, can you check it out who are on online? How many are there online? Kumar Sumi sir, Kutkuli. So what, like, I don't know the procedure as such, like you need to check it out. Is the quorum is ready for the GBM? Yeah, that anybody can say. Is there, you have any idea? Because only executive committee people, other than the executive, Siddhana, I need your help here. So to consider for the GBM, is there anything like number of people has to be there or anything? Yeah, so there is 20 people online, plus 3 people separate, four. Other than that, are all others are executive members. So executive members are considered to be the part of GBM as a total numbers. Okay, so shall we proceed? Okay. If anybody wants to say in online, you check it out. So by rules, we are supposed to do consider for every year GBM to be considered, but because of COVID, we couldn't do. So this is the first GBM for the 2021, and we are going to follow it up for the coming months, probably next month itself for the 2022. So we are like, actually what are we are done till now? Like if you see that in the moment we took over, like within 15 days, the COVID things announced and there was a lockdown, like ontara grahana tara aaytu anta. So it is, we had thought a lot of things. We expressed also when we started. In spite of that, we started around like online programs, 4 online program and 1 APGAR for the students. So that is in the year like 2021. So initially when we started with the online, that there was an excellent response overall, and like we saw that like even can we do it, but over a period of time we saw that everybody became busy and the COVID was so strong, like it's one or the other things are happening and the things get a little bit diluted. So the attendance at that time, especially the participation across Karnataka, was very good. So that is one thing. Thanks for that, and thanks for even the media team that like they're all like did the good job. So just to give a background that what was our thought process when we started. So we wanted to do at least once in 6 to 8 weeks, that is 2 months programs, and 1 for the internal, and then at least 3 programs per year, like site specific, include the other the specialties, medical oncologists, like site specific urology, neuroscience, like CNS, epidemiology, and gynae oncology. So that we couldn't do it. And also we thought of doing at least combined Gokarma along with Maharashtra, at least one per year. 2, and also we wanted to do give an opportunity for across Karnataka and do outside Karnataka at least once in 6 months. So at least 4 we wanted to do it, but we couldn't do. Sorry? Outside Bangalore. In Karnataka, like at least already the people who are already like come forward in terms of doing in Mangalore, go like it's Hubli and north and south, like all the places, but no. So here I would like to thank all the members across, and especially the executive members and across all the members of Aroi to we were able to do only like as much as possible. So in terms of 2020, 21, 22, we'll do that. Like next we can proceed for any specific. Yeah. We'll go for the Secretary's report.
Thank you, sir. So now we'll be presenting the report for the year 2021. So the present executive took over in March of 2021, and as sir has already told, as soon as we took up, there was COVID 2020, March of 2020. So after which a decision was taken that we will have only online meetings, as the physical meetings was not possible, and there were a lot of challenges regarding the quality of the meetings and also the connectivity issues and also the participation. But I'm happy to tell that in spite of that we were having good attendance. The average was about 70 to 80, but that was the peak. But usually we will not be able to maintain 70 to 80 to the entire program, but we used to have an average of 70 to 80 for every meeting online. So we had 4 meetings that we did. So we had 4 meetings that we did and 1 Abgar for the postgraduate students. Yeah. This is for 2021. Although 21-22 barutte. So these are the new members who became members in the year 2021. There were about 19 people who became members. These are the names of the new members of Karnataka Aroi. Next. So we also had the initiative of starting newsletters in the year 2020. So we had 2 newsletters that were released in that period. We have to thank Dr. Bindu Joseph, who was the editor. It was our initiative and hard work. We could bring out 2 wonderful newsletters, and the newsletters were appreciated from all the members within Karnataka and also other IRM members from outside Karnataka. And I will take this opportunity to thank our resident Dr. Hemant Vasan, who put in a lot of efforts to make the newsletter. Next. These were the 2 newsletters, but unfortunately we could not get sponsorship for these newsletters, and the effort it took was more, and somehow we could not continue it, but we'll try to restart it again. Next. So these were the academic programs that we have done. The first one was in May 2020, which was current concepts in Hodgkin's lymphoma, followed by one in September 11, 2020, which was current concepts in B-cell non-Hodgkin's lymphoma. And on Jan 29th, we had a joint CME with MS Ramaya Medical College, which was on cobalt-60 brachytherapy experience. And we had one meeting along with Department of Radiation Oncology, Kidwai Memorial Institute of Oncology, which was actually planned for February, but it had to be postponed, and we did it in the first week of April. But because it was already scheduled in February, I put it here. It was on ABC and prostate permanent implant experience from Kidwai. The average participation was about 7 to 9 to 90. Next. So these are the brochures of those meetings. Ideally, if the physical meetings had taken place, then would have put photos, but all were online. So I'm just putting this. Next. Next. So then we had an ABGAR program. This is a mock exams, practical exams for exam going PGs. So we conducted that on 5th and 6th of June 2020. It was attended by about 33 students who were all final year residents. In fact, there was a very good response, but we could not take more than 33. But we allowed the others who had registered to observe the program, but they could not be participated. And all of this was done online. And we had a lot of students applying from outside states also, especially Tamil Nadu, Andhra, West Bengal, and Delhi. Next. Next. So these were the list of students who participated. I don't know whether it's visible. There were 3 students from Chennai, 1 from Hyderabad, and 1 from Kolkata who actually participated. Next. So in conclusion, in the backdrop of COVID-19, the lockdowns and uncertainties, we tried our best to keep the association active with the academic programs. However, because of online meetings, we had an advantage that we were able to connect with other members of Karnataka chapter, because the meetings majority will take place in Bangalore, and only the Bangalore members used to come and meet up. Now, because of this online, we were able to connect with all of them, and we also had a lot of participation from other districts as well, from Mangalore, Manipal, Hubli. A lot of people participated, and we thought that even though now physical meeting is going on, we didn't want to leave it. So we are continuing the live streaming so that everybody can be part of the program. So I would like to thank the president and all the VC members for their cooperation and support, and all the members of Aroi. Thank you. I call upon Dr. Rupesh, treasurer, to present the financials for the year 2021.
Good evening, everyone. In 2020-2021 financial year, as we discussed, we could not do much of physical meeting. Most of it was online meetings. So there was not much of spendings from the account. If it is visible, the fixed deposit, which is 10 lakh, is remaining the same. The spendings was only some 56,000 something, 35,000 for the CME expense, and 20,000 for the journal expense, and TDS of 2,000. So other than this expense, there was not much of other expense. So we still have 10 lakh in the deposit and 1.75 lakh in the savings bank account. And the sponsorships given is to be added for the 21-22 period. Membership fees, I think that is in the next year, it has been added. 21-20. We got, but that,
That 1,30,000 was what we had previously done. AstraZeneca at 1 lakh. After that, one more, I think 2,000 something. Again, it was from the previous. That's why it is okay.
TDS 2000. That's all.
$26,000.
FD interest.
See, we had a fee from previous. We had about 8 lakhs in the FD. Okay, that was cash in hand. Okay, which was about 8,56,480 was the cash in hand when we took over. Okay, that included the 10 lakhs from the ICC fund, in which some part we had used because the sponsorship was delayed. So what happened after we took over, then we got the sponsorship which was promised. So in that, whatever we have collected, in that 12,35,861 was what was collected last year. Okay, and 2021. Out of that, 10 lakhs has again been FD. So now the total FD is about 18 lakhs. That was discussed in the previous GBM and permission was 18 lakhs as FD.
FD.
Beyond FD, we have about 1,77,714.
10 lakh. Year 10 lakh. 10 FD 10 lakh ಅಂತ ಕೊಡ್ಬೋದು.
It is coming into the
Savings.
It's coming into the account and we are using it. So actually, sir, incomes are only three incomes. One is sponsorship fees. Second is membership fees. Third is interest. Only 3 things we are getting income. And expenditure also. This time we had only 3. One is for that newsletter, permissions and all. We have to spend about 20 like a PDF license and all. Another 15,000 we have to pay for the CRT. Rest of the amount will be but between 10 lakhs we have made. The total is we have at hand 1,77,000. ಇನ್ನೊಂದು slide that is there in so cash it and yeah so this is what because what we look was not support not the US everybody that's it not brought as it is not next so the next point is the present somebody has to propose and somebody has to second. Okay, Dr. Siddhana proposed and Dr. Vikram is seconded it. So the next point is the present executive will come, the tenure will come to end now. So we have to call for fresh elections and also we'll have to nominate a election officer to conduct that. So because we have already gone 1 month late, what we thought was we will call now and probably within 3 to 4 weeks, we'll have another meeting, another GBM for the year 21-22. Because each year, as per bylaws, I think every year we have to do GBM. So because we had missed GBM last year, that GBM is done now. And for this year, we will do it in next month. And in the same time, the results will be announced and the transfer will be done. So if there is any suggestions for the election officer, we can take. Sir, suggestion, sir. Kumar Swamy, sir. Huh? Hello, BSR is now part of the executive. We cannot take it. Kumar Swamy, sir. Sir, only sir. No, we will call for election. Everything will be done and decision whatever will be there will be taken in the next GPM. But we will call for election, sir. No, it should be part of our association. Yeah. Sir, totally, sir, will. Ready just will forward it to you, forward it to everyone. That's all. Okay, so we have selected Dr. Siddhana sir as the election commissioner bar election officer for the election. So is there any point that needs to be discussed by the members? They can raise it. Online. Anybody has sent some? Anything? ಇಲ್ಲ ಮಾಡಿಲ್ಲ ಅನ್ಸುತ್ತೆ. When was it last done, sir? Even I don't know. I think in a previous term also it was not done. That was 5 years back almost. Then it must have. I will look into it, sir. Even I don't know this, I will check it. I didn't know about this. I will see. If anything needs to be done, we will re-register or renewal of the registration. Done. I'll just see what is that and I will get back to you. I was not aware of this. Any other point? So I think. So the permission of the chair, I think we will conclude the GBM. Thank you all members for coming and participating in the GBM. Thank you, Honorable. We'll go for the
sponsors.
So I would like to thank Rosh for providing the sponsorship for today's program. I think Kiran is outside, but I thank Rosh for doing this. Thank you.
Thank you.